and was hoping to give a role play on how to take the history at a breast cancer case. But it seems today we will discuss it anyway. Dr. Nalinda Mursing is ready with that. But it seems there had been a recent meeting and there had been a change in this observed history-taking scenario. So to mention further about it, I would request Dr. Sundu Kumarage, head of department, to speak about it a bit.
Can you hear me, Pinto?
Yes, sir, we can hear you.
All right. Okay. Now, last Friday, there was a meeting in the University Grant Commission. So they decided now this change of exam format is not only the history, the clinical part, the theory as well, the number of MCQs and the proportion of the best of 5 MCQs. Ultimately, they decided because most of the Colombo-based universities are for it and few others are not ready for it. So they decided to go ahead with the previous format this time also, but definitely from 2023 onwards. So you are sitting for final year in March 2022, isn't it? So to March 2023, definitely the new format will be the way they are going to hold the exam. So observed history taking and short cases in sort of 2 different ways will not be implemented in this time. Is it clear?
So that means it will be as per previous format where 20 minutes were given for the patient and student to have a discussion, and then about 20 minutes will be given for formulating the whatever investigations and then 20 minutes with the examiners.
For 20 minutes. Yeah.
Yes. So previous format will be done for the
history. Yes. After that, they will be given another 10 minutes to organize their thoughts, and 20 minutes with examiners again.
20 minutes more with the examiners. Right. Okay. So anyway, I think as there are 4th and 3rd years, both of them are there, and they will definitely have this observed history taking scenario.
From 2023,
I think we can go ahead.
March onwards, that means sort of including 2023 March exam, definitely the new format.
Right.
So that means the next batch who is going to do the final year.
Yes.
Current
next
4th
final year then. And even the students who fail or repeat in this time also has to get ready for observed history taking in 2023.
Right.
There won't be 2 exams.
All syllabus right. Anyway. So then shall we proceed then with the best case?
Yes.
Okay.
So we designed this as for the new format.
That's fine. Nalinda, because I think that is way forward. So we will proceed with that.
Yeah. So in this role play, I will be playing the role of the student, and DeLuca will play the role of the patient, and DeLuca is playing the role of a patient who is 45-year-old lady. So I will start the questions, and as per the new format, so Sumbu sir will be observing theoretically what we are doing. So he's directly observing what the patient and how the student performs and what he asks from the patient. Right. Diluk, are you up?
Yes. Yes, go ahead.
Let me ready with the timer. Right. Yeah.
Okay. So make Singaleng ahanna ne sir?
Yes.
Right. මම අවසන් වසර වෛද්‍ය ශිෂ්‍යයෙ මේ මට කියන්න පුළුවන්ද ඔබතුමියගේ නම මොකක්ද කියලා?
මගේ නම චාන්දනී.
වයස කීයද චාන්දනී? hello
hello
වයස කීයද
45
hello
වයස 45 ඇහෙන්නද
හරි දැන් clear
හරි
විවාහකයිද
විවාහකයි
දරුවෝ ඉන්නවද කී දෙනෙක් ඉන්නවද
දරුවෝ දෙන්නෙක් ඉන්නවා
ඒගොල්ලන්ගේ වයස් කොහොමද
එක්කෙනෙක්ට දැන් 15යි අනිත් එක්කෙනාට 10යි
15 දුවද පුතාද
එයා දුව
හරි දෙවෙනියත් පුතා
දෙවනියා පුතා
හරි චාන්දනී රැකියාවක් කරනවද
මම ඔය පොඩි ටෙලිග්‍රාමයක් වල එහෙම පොඩ්ඩක් රඟපානවා ඉඳලා හිටලා වෙනනම් ඉතින් ගෙදර වැඩ ටික බලන් ඉන්නවා
හොඳයි හොඳයි එතකොට චාන්දනී අද ආවේ දැන් මේ මොකද්ද අසනීප
ડોක්ටර් මේ මට මේ මාසෙක විතර ඉඳන් මේ මගේ දකුණු පියවරේ නිකන් පොඩි ගෙඩියක් වගේ අහු වෙනවානේ
හරි ඒක වේදනයිද කොහොමද දැනගත්තේ එතන ගෙඩියක් තියෙනයි කියලා ඔයාට වේදනාව හැදිලා බැලුවද නැත්නම් එතන ඔයා
නැහැ
සෝදත් හම්බෙන් දැනගත්තා
ඔව් ඒක තමයි මේ නානකොට පොඩ්ඩක් එහෙම අහු වුණා මේ අර අපේ මේ ක්ලිනික් එකක කියලා තියෙනවා මේ නානකොට මේ පියවර පරීක්ෂා කරන්න කියලා මේ කියලා තියෙනවා ක්ලිනික් එකක ඉතින් චෙක් කරද්දි තමයි අහු වුනේ
හරි දැන් මේ මාසයකට කලින් අහුණාට පස්සේ මේ වෙනකන් ඒකේ වෙනසක් දැනුණාද
ටිකක් ඒ හරිය ටිකක් ලොකුයි දැන් ඉදිමිලා වගේ කියලා හිතෙනවා
හොඳයි එතකොට එතන මේ ඒ පැත්තේ තනපුඩේ මොකුත් වෙනසක් තියෙනවද තනපුඩේ ඇතුළේ මේ ගිහිල්ලා තියෙනවා හැබැයි තනපුඩෙන් ශ්‍රාවයක් එනවා වගේ එහෙම මොකුත් වෙනසක්
එහෙමනම් එහෙම මොකුත් දීරයක් ගන්නවා වගේ එහෙම මම දැකලා නැහැ
හරි ඒ පැත්තේ මේ දකුණු පැත්තේ මේ කිහිල්ල ප්‍රදේශෙ මොකුත් වෙනසක් තියෙනවද වේදනාවක් හරි ගෙඩියක් හරි
වේදනාවක් නෑ ડોක්ටර් මේ කිව්ව හින්දා මතක් වුණේ නිකන් ගෙඩියක් වගේ නං අහු වෙනවා
හරි එතකොට පියුරේ තියෙන ගෙඩියට අමතරව ආයි කිහිල්ල ප්‍රදේශෙත් මොකක් හරි ගෙඩියක් වගේ එකක් අහු වෙනවා
ඒක තමයි
හරි එතකොට වම් පැත්තේ පියුරේ මොකුත් ගැටලුවක් තියෙද
නෑ ඒ පැත්තේ මොකුත් ප්‍රශ්නයක් නෑ ඒ පැත්තේ කිහිල්ලෙත් මොකුත් අහුුන්නේ නෑ මට
හොඳයි එතකොට මේ පියවර අසනීපේ මීට අමතරව කවදා හරි පියවර අසනීප තිබිලා ස්පිරිතාලයකට ගිහිල්ලා හරි ડોක්ටර් කෙනෙක් ගාව චෙක් කරලා හරි පරීක්ෂණ කරලා මොකුත් තියෙනවද
අපෝ යෝ ડોක්ටර් මේ අවුරුදු 18 20 කාලේ මට මේ දැන් 45ක් වෙනවනේ ඒ කාලේ මේ ඕම මේ පොඩි ගෙඩි දෙක තුනක් තිබිලා මේ සිහිය නැති කරලා අයින් කරානේ ඒව නම් හැබැයි මොකුත් ගැටලුවක් නැහැ කියලා කිව්වා
ඒවා චෙක් කරලා ඒ රිපෝට් වල ප්‍රශ්න නැහැ කියලා කිව්වද
ඔය අර පාඨක වාර්තාවක් බලලා එහෙම මොකුත් ප්‍රශ්නයක් නැහැ කිව්වා
ඒ දෙපැත්තෙම අයින් කරාද එක පැත්තකද අයින් කරේ
අම්මලා බය වෙලා අයින් කරමු කියලා අයින් කරා
ඔව් දෙපැත්තෙම අයින් කරාද නැත්නම් පියුරු දෙකේම තිබ්බද එතකොට නැත්නම් එක පැත්තක තිබ්බේ
දෙපැත්තෙම තිබ්බාගේ තමයි මතක හරියට මතක නෑ ડોක්ටර්
ඒවැ මොකුත් මේ වාර්තා මොකුත් ගෙනල්ලා නෑ අද නේද
ඒ අවුරුදු 20ක් විතර වෙනවනේ ડોක්ටර්
හරි එතකොට මේ චාන්දනීගේ අම්මගේ පැත්තෙන් තාත්තගේ පැත්තෙන් ඥාතීන් කවුරුත් ඉන්නවද මේ පියුරු පිළිකා එහෙම තියෙන
ඔව් ડોක්ටර් දැන් තාත්තගේ පැත්තේ නම් ගැටලුවක් නෑ අපේ දැන් අම්මට දැන් නම් ටිකක් වයසයි අවුරුදු 60 විතර වගේ අම්මට මේ ආවනේ මේ පියුරු පිළිකාවක් ඒක තමයි බය වෙලා මේ පටන් ගත්තේ හොයන්න මේක
අතට අම්මට පියුරු පිළිකාවක් තියලා එයාට ප්‍රතිකාර කරාද
ඔව් එයාගේ පියුර අයින් කරානේ සම්පූර්ණයෙන්ම අයින් කරා පියුර මේ ඉතින් දැන් ඉතින් ඉන්නවා ගෙදරට වෙලා මේ බේතුත් බොනවා
තාම බෙහෙත් බොනවා එකට
ඔව් තාම බෙහෙත් බොනවා එකට
හරි එතකොට මේ අම්මට අර කීමෝതെරපි කියලා ඉන්ජෙක්ෂන් කෝස් එකක් මොන හරි කරාද ඒක
ඔව් මහරගම පියුර අයින් කළා ඊට පස්සේ මහරගම යවලා ඉන්ජෙක්ෂන් කෝස් එකක් එහෙම දුන්නා
හොඳයි දැන් මේ චාන්දනීගේ ඥාතීන් කවුරුත් ඉන්නවද ඩිම්බ කෝෂ පිළිකා මහාන්ත්‍රේ පිළිකා බඩවැල් වල පිළිකා එහෙම මොකුත් නැහැ
ඒ වගේ දෙයක් ගන්න තරමින් නෑ ડોක්ටර්
හරි දැන් චාන්දනීට වෙන මොකුත් මේ පියුරේ ගෙඩියට අමතර වෙන කොහේරි අසනීප ඇතිනද දැන් ඔව් හන්දියපත් අමාරුවක් මේ කොන්ද කැක්කුමක් දන්නේ එහෙම අමාරුවක් තියෙද
හැබැයි ડોක්ටර් දැන් මේ මාසෙක දෙකකින් නම් මේ වම් පැත්තේ උකුල පොඩ්ඩක් රිදෙනවා ඔය පැනඩෝල් එහෙම ගත්තට එච්චරම අහන්නෙත් නෑ මම ඔය තෙලක් එහෙමත් ගන්නවා
අයෙත් දැන් මාස දෙකක් විතර
වගේ ඔව් මං හිතන්නේ
හරි කෑම කන්න බොන්න අප්‍රියාවක් මොකුත් නෑ කෑම කන්න අප්‍රියාවක් මොකුත් තියෙනවද ඇඟ කෙට්ටු වීමක් තියෙනවද
නම් එහෙම කන්න අප්‍රියාවක් නෑ ඇඟ පොඩ්ඩක් ඉතින් ඇදිලා ගිහිල්ලා කියලා කට්ටිය කියනවා
හරි එතකොට මේ ඉවසන්න බැරි ඔළුවේ කැක්කුමක් මේ විශේෂයෙන්ම උදේ කාලෙට එහෙම මුකුත් එහෙම තියෙද
නෑ එහෙම නෑ
පීට් එක වගේ ඇවිත් නෑ කවදාවත්
නෑ එහෙම නෑ ડોක්ටර්
හොඳයි. වාමන යන්නේ ඔක්කාර ගතිය එහෙම මුකුත් නැහැ නේද?
නෑ.
හරි. එතකොට වෙන අසනීප මුකුත් තියෙනවද? ඔය දියවැඩියා, ප්‍රෙෂර්, කොලෙස්ටරෝල්
නෑ ડોක්ටර් ළඟදී චෙකප් එකකුත් දැම්මා. මේ එහෙම මුකුත් අහුුන්නේ නෑ. ප්‍රෙෂර් එහෙමත් බැලුවා.
හරි. හති අමාරුවක් හුස්ම ගන්නකොට මේ පපුවේ ලොකු කැක්කුමක් කෙන එක එහෙම මුකුත් අමාරුවක් නැහැ.
නෑ එහෙම එකක් නෑ.
හරි. ඔපරේෂන් මුකුත් කරලා තියෙනවද?
අර ડોක්ටර් අර පියුරිය පොඩි ගෙඩි වර්ග අයින් කරලා කිව්ව සී නැති කරලා එච්චර තමයි.
ඊට වෙන මුකුත් කරලා නැහැ. බබාලා එහෙම හම්බුනේ
නෝමල් හම්බුනේ.
normal right okay බෙහෙත් වාති කෑම જાති ප්ලාස්ටර් එහෙම විස වෙලා ඇලර්ජි වෙලා තියෙද?
කිසිම ඇලර්ජික් එකක් නැහැ ડોක්ටර්. මේ බෙහෙත් එහෙම බොල් බීලා තියෙනවා මුකුත් වෙලා නැහැ.
හරි. එතකොට දැන් මේ චාන්දනීගේ ගෙදර මේ හස්බන්ඩ් හරි කවුරු හරි ඉන්නවද වෙන කවුරුත් දුම්පානය කරන?
බන්නම් ටිකක් මේ ස්මෝක් කරනවා ડોක්ටර්.
එතකොට ඒ දුම ඔයාට එනවද?
ඔව් හස්බන්ඩ් සමහරට ඉතින් කාමරේ ඉඳන් තමයි ස්මෝක් කරන්නේ ළමයි දකින්නවනේ.
ඒකින්ද. එතකොට ඔයා දැන් මේ ටෙලිනාට්‍ය වෘත්තිය කියවනේ ඉන්නේ. එතකොට ඒ තැන්වල ඔයාගේ යාළුවෝ එතන මේ දුම්පානය කරනවද? ඔයාට දුම එනවද?
සීන් එකේ ඉන්නේ නැති වෙලාවට ඉතින් මේ හෙලෝ ගහනවද?
yeah
ඔව් එතනදී ඒගොල්ලෝ ඉන්නවා ඉතින්.
හරි. දැන් මේ සම්බන්ධව ස්පිරිතාලට ඇවිල්ලා මොන හරි පරීක්ෂා කරාද? ඔයාගේ පියුරුවේ මොන හරි එක්ස්රේ වගේ ගත්තද? මේ තහඩු දෙකක් වගේ ප්ලේට්ස් දෙකක් වගේ උඩ තියලා?
ඔව් ડોක්ටර් මේ අපේ ගමේ ડોක්ටර් මුලින් හම්බෙලා ගියාම එයා මේ කිව්වා මේක මේ බල ඉඳලා හරියන්නේ නැහැ කියලා අර මැමෝග්‍රෑම් කියලා පරීක්ෂණයකුත් කරා.
එහෙම කරා.
ඔව් අර කළු පාට මේ මට ડોක්ටර් කිව්වාගේ අර මේ පපුව නිකන් තලලා වගේ නිකන් ඒ වගේ මත පරීක්ෂණයක් කරා. ඊට අමතරව මේ ස්කෑන් කරලා මේ කට්ටකුත් ගැහුවා.
කටු පරීක්ෂණයක් කරාද?
කටු පරීක්ෂණයක් කරා. ඒකට හරි රිදුනා මේ
ඒ කටු පරීක්ෂණය කරනකොට එතන හිරිවට්ටලද කරේ නැත්නම් නිකම්ම
කරා? ඔව් හිරිවට්ටලා පොඩි කැපුමකුත් දැම්මා වගේ නිකන් නිච්චයක් තියෙනවා.
හරි. දැන් ඒවැ වාර්තා හැම හම්බෙලා තියෙන්නේ. එහෙම ඔයා ගැන ඔයාට මොකුත් දැනුවත් කරාද?
ඒවැ වාර්තා නම් ડોක්ටර් මාගාව තියෙනවා. මට හැබැයි දැනුවත් නම් කරේ නැහැ මොනවද තියෙන්නේ කියලා.
හරි. right okay Sumal sir?
Yeah, good. It's almost 8 minutes. Now the rest is the examination. Usually observed history taking, it's 15 minutes encounter, but usually I think 6 to 8 minutes is good enough to take a comprehensive history. And another 3 to 4 minutes is good enough to do a focused examination, general and local examination. We may not be able to do the examination, but can you just highlight what are the important or focused aspects of general examination in this patient with this history?
So you want to talk about the examination?
Yes.
Yeah. So this patient is now, she's a premenopausal lady who is complaining of a right side breast lump, and she thinks that there's some lumpiness in lump in the same side axilla as well. So when you're examining, first you will do a general examination because the patient also complained of a left side hip pain which is not responding to ordinary analgesics. So the patient might be harboring a cancer with metastatic disease. We don't know. So when you are doing the general examination, you have to keep in mind all these things and do a general examination focused at detecting the signs and the symptoms, the signs of metastatic disease. So you start from head and go to the toe, right? So you see how the general appearance of the patient, because she said that she feels that she has lose bit of weight. So although she has not noticed any loss of appetite, she thinks she has lose some weight. So you have to assess the general condition, whether she is cachectic or whether she is asthenic. Then the usual build. Then you start whether she is anemic. You can check the Popello, the sclera, and you can see whether she is icteric. I know students are very
fond of that.
Very fond of that because, but if you dig into the details and see how a patient will develop icterus due to a metastatic deposit in the liver, the only scenario I can think of is where a porta-hepatic nodal mass that is occlude in the left hepatic duct and the right hepatic duct. So that apart from that, isolated metastatic.
Very unlikely scenario.
Yeah, apart from that, isolated hepatic deposits in the parenchyma will not cause obstructive jaundice. So it's not if you see something you can tell, but otherwise you don't have to stress on that. Then you can see the edema, the ankle edema, whether there's any loss of protein because there's a asthenic patient, or if the patient might be having dietary complications if they can't eat, but this patient per se didn't say that. And you start examining then the breast. So you have a chaperone in the exam. You don't have to worry. There will be a chaperone, whether you are a male or a female. Examine this female patient. So there will be a chaperone. Don't worry about that. But you have to ask for that. Then you have to make sure that the patient's dignity is maintained. So adequate. You have to pull the curtains and make sure there's adequate lighting. Then you have to undress. Ask the patient to undress. I mean, you can tell her what to do to take all the top half off. So if the patient is wearing a blouse and a bra, you have to tell them take the blouse and bra completely off. So the chaperone will also assist. So don't examine the patients. Ask them to pull their blouse top upwards and examine halfway. That is like pornography. Don't do that too. This is a clinical medicine. So you have to ask them to completely undress, and then you can use a different sheet to cover one breast at a time if you want to do that. So the breast examination, classically you start with the patient in the seated position, right? So that's where you do the full inspection. So you can the patient's hands by her side. So you can assess the breast shape and volume, whether they are symmetry or asymmetry for shape and volume. Then the color, whether there are any erythematous areas, swollen areas, edematous areas, and what is the state of the nipple, whether they are protruded and everted and slightly looking lateral. So if you see inverted, retracted nipples, or if you have seen anything, any ulcerated or nipples suggestive of Paget's disease, then you have to be mindful about that as well. Then you can ask the patient to raise their hands above the head to see whether there's any accentuation of any skin defects, so which is not readily visible when the patient's hands are by her side. So you will see the dimpling and puckering. So these things can be seen. Now, tethering is something you will appreciate on palpation. So classically, if you see the Oxford dictionary, tethering is something you will feel, not something you will appreciate on inspection. On inspection, you will see puckering. So, but both of these signs are not suggestive of skin involvement. Okay, it may suggest that the underlying lesion is close to the skin, but it doesn't suggest that the lesion is involving the skin. Then, any questions up to now?
Any questions from students? I will proceed.
Yeah. Okay. Yeah. So then you have to ask the patient to lie down, and it is best if you can keep the patient in a semi-recumbent position, a 30-degree or 45-degree angle, and you have to ask the patient's hand to keep the hands behind her head, right, folded behind her head, the palms. So there's enough room for you to do proper examination. So you have to tell the patient, you know that the patient's symptoms are on the right side, but you will be starting with the normal side, which is the left side. Otherwise the patient will panic what's happening, because she complained of right side breast symptoms and we are going to examine the left side. So you have to first tell them, so then there will be no misunderstanding, right? So you examine the contralateral breast with your flat hands, the fingers, not the tips of the fingers or the palm. It should be the flat surface of the fingers, right? And you can do either clockwise or anti-clockwise pattern palpation starting from one end. But make sure you examine the whole entire breast without leaving any skip areas. So patients, the students come with the idea that they need to identify, the palpate the 4 quadrants, and they will palpate. If I describe as in a clock, they will examine the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So that's the 4 quadrants that they do. But the from 12 to 3 area, that huge quadrant is skipped, and 3 to 6, that area is skipped. So there will be a lot of skip areas. Don't do that. So you have to examine it, and especially if it is a large breast, so there will be a lot of missed areas that you didn't properly palpate. So you take your time and gently do a clockwise or anti-clockwise examination or the palpation. And if it is a large breasted patient, you have to support the breast laterally with your other hand to move it medially. Okay. Then when you're examining in a clockwise or anti-clockwise manner, and if you come across an abnormality, what everybody, the breast surgeon says, not to stop there. So you continue with your examination, and you come back at the end of your examination to the abnormality that you detected. Then you in depth examine that area. Understood?
Nalinda,
Yeah.
just one question now. Say there's a small lesion, and is it a good idea to ask the patient to point where the lesion is actually in the breast?
Yes, definitely, Arun. That's fine. So very fine lesions, although which we do not appreciate at a lesion as a lump, it may be a small dense breast tissue, but the patient is worried whether that is a lump. So that's the lump that they came and complained of initially. So it's better if you ask the patient to point to the abnormality that they detected if you can't find a lump. That is exactly correct. Okay, now then you can come to the ipsilateral side and do the examination. Then when you are appreciating a proper lump, so there are two things, no, mainly a lump. That's a proper lump that you can feel well defined abnormality. But sometimes, rarely, you will come across a nodularity, especially in these lobular cancers, invasive lobular cancers. They are not very well defined lumps. So it's a vague area of nodularity that you will appreciate. But if you have examined these invasive lobular cancer patients, clinically you can tell, okay, now this could be a cancer, but it feels malignant, but it could be a invasive lobular, which we do not expect at your level at all. But if you have done it, you can appreciate that as well. So what I need to tell you is, it is not always a lump that you will feel. So sometimes there will be an area of nodularity, but most of the time in your exam setup, it will be a proper lump. So the things the clinician wants to look at when they are examining a breast lump is the how it feels, the consistency. So usually in a malignant suspicious lump, it feels very firm to hard in consistency, but it's not hard, it's firm to hard, and it feels very with ill-defined borders, ill-defined margins, and most of the time it is mobile over the chest wall and over the skin, but within the parenchyma you can appreciate that it is not mobile as a fibroadenoma. So fibroadenoma is freely mobile. It is mobile over the chest wall, or mobile under the skin, and it is within the parenchyma also. Sometimes you can move it easily, but the malignant breast lump is not freely mobile within the breast tissue. Okay, and you need to get an idea about the size, because it's important for the TNM staging. The less than 2 centimeters is T1, then 2 to 5 centimeters is T2, then more than 5 centimeters is T3. So it's directly affecting the TNM staging. So we need to clinically have an idea about the size of the lump. Then we need to see whether there's any signs of skin infiltration or underlying chest wall infiltration. So how to do that? So oncologically, there are only 3 scenarios to say that the tumor is involved in the skin. That is to mention that is qualifying for a T4. So if it is having direct invasion to the skin and making an ulcer, so that is 1. Or if it is having body orange appearance, the skin like a skin of an orange peel. I'm pretty sure you all know what is body orange appearance, and that is 2. And third one is if there is any metastatic skin nodules on the skin. So these are the 3 scenarios that is qualifying to become a T4B cancer. So T4A means infiltration of the chest wall. So you can easily see, examine the patient when the patient is lying down with the patient's hand by the side, relaxing. You can mobilize the lump and see whether it's freely mobile over the chest wall. Then you can ask the patient to press against her hips with the hands and see to contract the pectoralis major and see whether that mobility is getting restricted. So that is T4A. If you have both chest wall infiltration and skin infiltration, that is T4C. And if you have evidence of inflammatory breast cancer, that is body orange with erythematous skin over more than 1/3 of the breast, that is qualifying for a inflammatory breast cancer. So if you have inflammatory breast cancer, that is T4D. Is that clear up to now? Yeah. Students, are you all clear?
They are muted.
Are they are still with us? I don't know whether
Yes, they are.
Okay. I hope they are not confused. Right. Okay. So I'll go on. So that's the palpation. So when you need to, then you need to examine the axilla. So when you are examining the axilla, okay. So about the nipple. So I always tell the students during the breast examination, when you are palpating the breast, there are 3 gray areas. So first gray area is the nipple areolar complex. So you will examine the palpate the breast, but you will not palpate the nipple areolar complex. So you need to separately examine the nipple areolar complex. There will be some nodules, suspicious lumps beneath the nipple areolar complex. Okay, so you need to examine that area. Second area is the inframammary fold. Inframammary fold is very important. It has a completely different anatomy to the rest of the breast. So that's why it makes a fold. That's why the anatomy is different. That's why it makes a nice fold. So inframammary fold has to be examined separately. Then the third area is the axillary tail. So axillary tail, that is not coming to the axillary examination. It comes under the breast examiner. You need to examine the axillary tail because it goes and hides beneath the pectoralis major fold. That is the anterior axillary fold. So you need to examine that area as well. Then you can ask the patient to, now other thing, even if a patient complains of a nipple discharge, please remember, don't squeeze patient's nipple to see whether there's any discharge. If you really want to see whether there's a discharge, you can ask the patient to squeeze and show whether the discharge is coming out or not. Never squeeze other patients' nipples in the exam or anywhere, even during your practice. Never do that. It's not ethically correct to do that. Okay. The other thing, to examine the axilla, you have to ask the patient to sit up, and it's difficult to explain how you do it. So for example, if you are examine the right axilla, so you have to keep your right hand on top of the patient's right shoulder, and you have to ask the patient to rest their right hand over your right forearm. So it will, and you need to ask the patient to leave it like that, and to then it gives you enough space and room to examine the patient's right axilla with your left hand. And the same thing can be repeated onto the left side. And when you examine the axilla, you have to, when you examine, you have to examine the axilla against the chest wall. Okay, you have 5 groups. You have the anterior, posterior, lateral, and the apical group. So you have to examine each and every group. Is that understood?
Yes, sir.
Right. Okay. So, Sumul sir, anything else we need to discuss?
Okay. There is very comprehensive examination of sort of general exam, focused general examination and breast examination. And if there is any evidence of, for example, if he has sort of evidence of bony pain, bony tenderness, more detailed examination of the spine and areas of tenderness is important, and and examination of the chest is also important, because that's a common site to get metastatic disease. But chances of you clinically detecting metastatic disease is unlikely, but you have to show that sort of, or at least sort of you should make an attempt to do that. Right. Nalinda, so at the end of your now examination part, we can safely omit because it is not done. So at the end of your history, can you summarize? Because this is the most likely question you will be posed at the end of your history. So it is very difficult to sort of summarize, right? It is not repeating the history. It is sort of summary is very important. You have to summarize within 1 or 2 minutes. Can you summarize the history of this patient?
Yeah, so this is a 45-year-old premenopausal lady with 2 children, who is a teledrama actress by profession, presents with a right breast lump for 2 months duration, which was detected incidentally. And she complains of left hip pain, which doesn't respond to ordinary analgesia for the same duration. And she has a family history of breast cancer, because her mother had breast cancer and undergone mastectomy at the age of 60. She doesn't have any other systemic signs or any other medical comorbidities, or not undergone surgeries except for benign breast lump excision 20 years ago.
Right, very good. So summary, you don't have to say everything which you have taken in the history. So you pick up what is important and which is more relevant. If you miss 1 or 2, it's not a grave mistake. And summary, everyone should be able to summarize patient's history, because that is what we expect as from house office also. Right. So at the end of this history, we know her problem is in the breast, right breast. And the next the issue is sort of what is the likely pathology behind her problem, Nalinda.
Yes.
What do you think it is?
So now the history itself is very, very worried and very suspicious of whether this is underlying, the lump is, whether it's due to underlying malignancy, because the patient has detected this about 1 month back, but now she also noticed that the lump is increasing in size. So other thing, now she has recently noticed that there's a lump appearing in her axilla as well. And she is telling that she has some bony pain in her left hip, which is not responding to analgesics, and she has a positive family history of breast cancer. The one thing I want to highlight is, although I included this family history, the mom had a breast cancer at the age of 60, that is not increasing her likelihood of a familial breast cancer. Because the mom has had this breast cancer at the age of 60. So anybody who had breast cancer more than 40 years in their families, from your mom's side or dad's side, those are not going to be calculated as familial, the risk of getting a familial breast cancer. But if
does it increase the risk of developing a breast cancer if there's a family member had a breast cancer at the age of 60?
No. So you will have an increased risk of breast cancer if your family member had breast cancer at 40 years or less than 40 years, or if your family member had bilateral breast cancer at less than 50 years, or if you have a male patient with breast cancer, you will indefinitely increase your risk.
Is the paternal family history also increase the risk of developing breast cancer?
Yeah, it's given same weight and risk stratification as for the maternal part.
Right. So if I ask sort of what are the risk factors for developing breast cancer in this patient?
Yeah, so this patient, we can say only the exposed to smoking. I mean, we didn't discuss about the oral contraceptive pills, but oral contraceptive pills or Depo-Provera, there is a risk, but only if you continuously use them for more than 10 years. But nobody is using that, so there will be breaks. So there's no big risk, and the studies also has not shown that there's a direct link with the combined oral contraceptive pill. Only the problem comes with the HRT, not in this patient, but in generally HRT has been overly and overshot. Then we got the latest study from Oxford University 2018, which reconfirmed the risk of HRT causing breast cancer, and that they mentioned in the conclusion that is also possible if it is used more than 10 years. So what we have to tell the patients is, if you want to use HRT, that's fine, you can use, but not at a stretch. You take intervals at least after 5 years, and you need to start have a mammogram before you start your HRT, and you have to have a routine mammogram once in 3 years, and in between they have to examine their breast monthly, and if there's any change, they need to go and see their doctor.
Can I ask one question?
Yes.
Does this Depo-Provera carries the risk of breast cancer?
No.
I thought it just is estrogen therapy which causes breast cancer.
POP pills, progesterone only pills, or progesterone injection has not shown to cause any risk of breast cancer. Even the combined oral contraceptive pill, which has estrogen, there is bit of risk of breast cancer, but not as what we have found out with HRT. So you are correct. So progesterone, it's safe. So Depo-Provera and progesterone only pill, what we call the POP, is okay to use for contraception.
Nalinda, now this patient, the eldest, she's 45, and eldest child is 15 years.
Yes.
So she didn't have children until 30 years. Yes. Is it a risk factor to develop breast cancer?
Now, theoretically, if you see all the theory books, yes, it is. We say first child after the age of 30 years, you should take it as a risk factor. But apart from that, in reality, we haven't seen that there's a direct link like that. So even the patients, most of the patients, the students in the exam say early menarche and late menopause, there's a risk factor. Okay, that's fine. That you can only calculate for the postmenopausal ladies. So if, for example, this patient, the case we discussed, 45-year-old lady, if they are still menstruating, you can't calculate that. What we are worried about is that whether the breasts are exposed to estrogen and how long they have been exposed. So studies have shown if the exposure is more than 42 years, the duration of exposure is more than 42 years, there might be a risk. So that is also not proven. So you don't have to give undue weight in your exam to highlight these things. So it's okay if your patient is postmenopausal and they attain menarche at 11 and menopause at 53. So then there's a long duration. You can tell that there is something like this, but in research they haven't been able to sort of define a time frame how much. If it is more than 40, whether there is any definite risk of getting malignancy or not, they have failed to show that.
Now, they say pregnancy before 30 years is safe for sort of, if it is late it's a theoretical risk of developing or higher risk of developing breast cancer. Now, is a miscarriage or abortion, ectopic pregnancy, are these also protective before 30 years, or they don't have a significant value?
They don't have significant value. But what we expect is with the pregnancy, the changes that occur in the breast, how whether the breasts are becoming primed with the pregnancy changes and getting ready for lactation, and those changes, whether they have occurred. So if you have produced a baby, they have delivered a baby, then it has some effect. But if the miscarriages, abortions, those are not counted.
Right. You said about smoking. What is the place of alcohol?
Alcohol and smoking, yes, both has a direct link with breast cancer risk, and it has been shown, and whether its value in the significance in giving rise to breast cancer as in other colorectal cancers and esophageal cancer. So there's nothing new. It's solid evidence, we have to say, that smoking and alcohol both are involved in giving rise to breast cancer.
Is breastfeeding protective for breast cancer?
Yeah.
The duration of breastfeeding and...
So when you're speaking about that, Sumulu sir, now the problem is in the West, if you ask 100 patients, 99 will say they haven't breastfed. Only one would say, or 1% will say they at least tried breastfeeding. But it's the quite opposite in Sri Lanka and the Southeast Asian region. What I understand is less than 1% will say no, they couldn't breastfeed. So it's protective to breastfeed. There's no question about it. It's very good. It's something you need to do as moms. You have to provide the nutrition to the baby. But what happens in this part of the world is that there is no age limit that you will stop. Even the patients, sometimes I ask the patients who are the babies who has going to 4th grade, 5th grade in the school are also coming home and still they are breastfeeding. So that is not good, because now naturally the breasts, the lactating mom, their levels of hormones are at a pretty high level to maintain prepare the woman for lactation. That's why they don't get menstruation also during the first 6 months. And naturally what it does is it drops the hormones. No, so then the patient will start to get menstruation. And by 11th or 12th months, baby also will develop teeth, because they need to have now solid food for their nutrition, because milk is not going to provide adequate nutrition. So even if you continue to breastfeed, that is not going to be protective. So additionally, you will see more other disease states of the breast, especially periductal mastitis, non-lactating mastitis, and breast abscess formation. So, and there are some papers to say now, especially coming from America, the first 10 years after a pregnancy, the woman is at a higher risk of developing breast cancer because of the hormonal surge that occurred in the pregnancy and lactation, and the breasts are exposed to that. Because of that hormonal surge, the woman is at increased risk of developing breast cancer for the next 10 years. So if we try to breastfeed the babies for more than that, so what we see, if the 8-year-old also being breastfed, your hormonal levels are not going to drop to the normal level. So they will be at a higher normal level. So which is not good.
So now this patient, you feel sort of this having a clinically suspicious breast lump.
Yes.
So is this suspicion good enough to go ahead with definitive treatment, or do you need to confirm this suspicion?
Yeah, that's a good question. So now, how much suspicious you are, you should not proceed with treatment unless you have solid evidence. And in today's setting, you need to discuss this in an MDT setup. So although you are clinically worried, and your history and your examination, you are worried now this is a it should be a metastatic breast cancer or local regionally advanced breast cancer. but there's a path to be followed. There's a way to be, for confirmatory test to be done and way to treat. So the next step is for a mammogram. So she is more than 40 years. So anybody who is more than 40 years with any breast symptom, you can get a mammogram done. So you will do a bilateral mammogram. The standard views are the craniocaudal and the mediolateral oblique. And depending on those, then you do a ultrasound scan. So the most important thing is the mammogram, not the ultrasound scan, because mammogram assesses the, it's a snapshot view of the entire breast in two views, both breasts, and it assesses the differences in the anatomical nature of the breast tissue. So you will see the dense, high density spiculated margins, then the architectural distortions, dermal edema, then you will see pleomorphic heterogeneous microcalcifications. So these are all suggestive of a malignant lesion, which is BIRADS 5. So you need to know what is BIRADS, is breast imaging reporting and data system 1 to 6. So you have the classification. So they can be asked in the exam. So then you need to do a ultrasound scan, which is a more focused assessment of the lesion that you have noticed clinically and mammographically. Then during the ultrasound scan, if you can see the lesion, most of the, about 90% of the time, you can, what you can palpate and detect mammographically, you can also see through the ultrasound scan. Then you have to do a guided co-biopsy, not an FNAC. So the place for FNAC in breast has it's gone now. It's not there anymore. So you have to always do and assess with a co-biopsy. But the very rare instance where you can feel only a nodularity, when there's no lump to be seen even in the ultrasound scan, then you can do several passes through that abnormal area with a fine needle to get some cells for cytology. But apart from that, if you have a lesion to target, you have to always do a ultrasound guided co-biopsy. And it has a lot of benefits. You not only diagnose the cancer, and you will diagnose what sort of a cancer, whether it's invasive lobular, invasive ductal, then whether there's any precancerous changes like the ductal carcinoma in situ, the in situ components, then also the histological grading, what we call the Nottingham grading of the cancer. So a lot of things to be done. And also you can proceed with the immunohistochemistry to see the receptor status, the ER, PR, and the HER2 status can be confirmed. And if there's a suspicion whether this is a lobular cancer or a ductal, then you can proceed at the same time what is called the E-cadherin test. It is also immunohistochemistry to confirm. So there are a lot of benefits in doing a co-biopsy over a fine needle aspiration. Because if you do a fine needle aspiration, and if it is even C4, that is not good enough for you to go and operate. Because you can't do a wide local action or a mastectomy, sort of a oncological surgery, depending on that. So you need to be 100% confirmed. If it is C5, yeah, I can't say don't do. If even it is C5, you not to do it. If it is C5, you can proceed. But the place for FNAs is it should be it's dropping, and the co-biopsy is the standard now. It's the gold standard.
Yeah, Nalinda, now you said now in the triple assessment, clinical assessment, radiologically in the form of mammogram and ultrasound, and then histological assessment with co-biopsy. These are the must which you have to do, or the bare minimum you have to do before proceeding definitive management. Now, now, why do we do bilateral mammogram and bilateral ultrasound? He's complaining of a problem in one side.
Yes.
So aren't we exposing unnecessary radiation to the other side?
Yeah, that's very good, sir. So we do bilateral mammogram. So anything that is not clinically palpable and the patient is also not symptomatic, there can be 8 to 10% of chance that there might be an abnormality in the other breast also. And especially if your breast cancer, the one that is symptomatic and one that you can palpate, if it is being reported as a lobular cancer, invasive lobular, because invasive lobular is notorious to be multifocal or multicentral in the ipsilateral breast, and no, it can occur in the contralateral breast also. So that's why the benefit of doing a bilateral mammogram. But you don't have to do bilateral ultrasound scan. But in Sri Lanka, usually even if you ask to do a right side breast scan, they will do bilateral breast ultrasound scan. That is okay. But the mammogram has to be done bilateral because of that reason, where there might be an impalpable lesion, impalpable abnormality, which needs to be further clarified. So it's not common. It's about 8 to 10%.
So they are having a higher risk of having breast cancer in the other side, or
Yes.
other pathologies in the other side as well.
Yes.
Right. Same in colorectal, we do a total colonoscopy.
That's
We
right.
examine the entire colon.
Yes.
That's again about 5% chance of having synchronous cancer. Right. So you said sort of you do receptor status
Yes.
of your core biopsy.
Yes.
It is quite a little different to the colorectal work. We don't do receptor status straight away in the biopsy specimen, but we do on the histology specimen or resection specimen. Right. And you mentioned you are targeting at mainly 3 receptors.
Yes.
Estrogen receptors, progesterone receptors, and HER2. HER2 is it a receptor or a gene or a protein? What is it?
It's a receptor. It's a HER2. These are normal human epidermal growth receptors. These are usually there. So you won't see a report saying HER2 is 0. It can't be 0. It's normally there. So the minimal that you can say is 1 positive. That is normal. 1 positive is normal. So and if it is 3 positive, that is abnormal. Then you are regarded that as HER2 positive. And HER2 2 plus means that is equivocal. So you can't be sure whether it's positive or negative by immunohistochemistry. In those patients, you have to proceed with the FISH testing, that is fluorescence in situ hybridization testing, to confirm if the HER2 is tested reported as HER2 2 plus in the immunocytochemistry.
Now, if you do a biopsy on a normal breast,
yes,
do they get estrogen and progesterone receptors?
No, they don't get. So that's one way how they clarify whether the tissues, whether if they are not sure whether this is a malignant lesion or not. So they do testing for the ER and PR state, and they say those are not stained with those. So if it is negatively stained, so that they say it's not.
Right. So what is the percentage of positivity and clinical significance of these receptor status?
So you will get what is called you score it out of 8 out of 8. So the minimal score is 0 and the maximum is 8. So if it is strongly positive, you will get 8, and if it is negative, it's 0. So when you have a estrogen and progesterone receptors are positive, that is hormone receptors are positive, and your HER2 receptors are negative, so those are the tumors that are having a better prognosis. So because simply because these patients can be treated with if they need chemotherapy, you can give chemotherapy. If they need radiotherapy, you can treat radiotherapy. But apart from that, you can treat this group of patients with endocrine therapy, which is going to happen for at least 5 years. Now there's something called the extended endocrine therapy also, which is extended for 8 to 10 years in certain conditions. So they have seen definite beneficial effect in these patients who are treated with endocrine therapy. That's why their prognosis is becoming better. So simple reason is that.
So
and
basically, estrogen and progesterone, ER and PR positivity is a good thing.
it is good. Yeah.
And HER2 positivity is not so good.
HER2 positivity is not so good. Their prognosis will be poor. So even if you have hormone receptors positive and HER2 also positive, then their prognosis is going to be bad.
So, so what is the importance of triple negative, or what do you mean by triple negative breast cancer?
Yeah, triple negative is where estrogen receptors are not sensitive, it's 0. Progesterone receptors are also not sensitive, that is also 0. And HER2 also 1+, it's negative. So all three are negative. In this is a very different group of breast cancer. The prognosis is very dismal, and you can only treat with chemotherapy, but even chemotherapy is not very, it is sensitive, but some of now, even if you say triple negative, there are 6 variants of triple negative breast cancer. So out of that, 4 are very responding to very sensitive to chemotherapy, but again 2 are not. So those people will not respond to chemotherapy even if you give. So anyway the triple negative group is not having a good prognosis, and these triple negative breast cancers tend to be most of the time younger patients who are less than 40, and the familial breast cancers are they tend to be triple negative in nature.
Do they have a higher incidence of BRCA1 positivity as well, or?
Yeah, that's why I said, so the familial tendency, the genetic involved BRCA1 and 2 patients can be most of the time are triple negative, but not always. So recently I had a patient with BRCA2 positive, but she was weekly hormone receptors positive. She ER5 and PR4. So it's still not triple negative. But so BRCA1 2 patients positive, gene positive patients, most of them are triple negative, but not always.
Right. So is that sort of now, if they have, as they have sort of negative ER and estrogen receptors and progesterone receptors, the hormonal manipulation in the form of tamoxifen or aromatase inhibitors are not very effective.
Yes.
And as HER2 is also negative, they are not very responding to anti-HER2 like the targeted therapy.
Yes, target. Yeah, that is trastuzumab, bentabert.
Yeah, those things as well. So these are the category of patients who have a very poor prognosis of breast cancer, and they tend to have familial breast cancer, and sort of they usually develop in young age.
Yeah, they develop at young age, and they tend to recover very fast. So the disease-free survival and overall survival is very low.
And metastatic disease also.
Yeah, they will have metastatic disease.
Right. So what is sort of the basic or treatment strategy of breast cancer now with a curative intent?
Yeah. So patients with who are undergoing breast conservative surgery, that is wide local.
I would ask in this way now. This patient is having a breast cancer. Suppose T2 lesion with positive lymph nodes in the axilla. Do we have to take separate biopsy from the axilla as well before embarking on definitive treatment, or sort of mammography evidence of or radiology evidence of lymph nodes is good enough to classify it as positive axilla?
So if the mammogram is and the ultrasound scan is definitely saying it is involved nodes, that's fine. That is, you can take it. But if you have any suspicion, you have to always do a core biopsy of the lymph nodes or a FNAC, because in our setup, the radiologists are not comfortable in doing core biopsies of the axillary nodes, especially if they are located close to the great vessels in the axilla. So, but if you ask, they will do FNAC. But if the mammogram and the ultrasound scan is saying there are involved nodes, and if clinically also those are positive nodes, then you have to do a axillary clearance. You don't have to get another biopsy. Patient
so they has a T2 lesion with radiologically significant lymph nodes in the axilla, but radiologically significant nodes in the axilla. Do we have to do other investigations to see whether he has got metastatic disease? Suppose this patient didn't have hip pain.
Yeah.
Or we do those investigation only if they have any symptoms related to metastatic disease?
No, it is like this. So not like in other cancers. So in breast cancer, you don't do staging contrast CT prior to surgery in all patients. So sometimes if there is a metastatic disease, if you suspect anything like that, if there's a pleural effusion, if there's a bone deposit, then you will do. And other thing, if you have a T4 cancer, yes, you will do. And otherwise, you will go carry on with the surgery. And in the surgery, there are certain criteria to do after surgery. So if the NPI is high, that is more than 4.4, or if the axillary nodes are 50% involved or more than 10 nodes. So if I say, for example, you do a axillary clearance and you have cleared 20 nodes altogether, but only 7 has involved nodes, metastatic deposits. So then in that case, that is not a criteria to go for a contrast enhanced CT for staging. But if you have removed 20 nodes and there are 10 nodes, at least 10 nodes involved, then you can do. Or if they are removed only 10 nodes after the axillary clearance and the 4 nodes are positive, still hello. Yeah. So if you have removed 10 nodes and 6 out of that is positive, still you will do 50% or more than 10 nodes involved, you will do. Oh yes, the NPI is high.
I can ask one question. In the place of MDT, can you restress the situation where you call for the MDT? Really, is it immediately after you tentatively diagnose the breast cancer by just clinical palpation and history, or is it after confirmatory evidence that you have after the imaging and all?
No. So when there's a patient and you have done the clinical workup, so that is you have clinically assessed and you have done the mammogram and ultrasound scan, then you can discuss in the MDT. So you, even if the patient is awaiting the core biopsy, you can put it to the MDT sometimes, because there are a lot of things to discuss in the sometimes in the imaging itself, the mammogram ultrasound scan. So clinically you may be suspicious, but the mammogram ultrasound is not that suspicious. So then there's a controversy, there's a conflict. So then you can discuss in the MDT setup.
So who are the members involved in this MDT?
Very good. So you will have the breast surgeon or the general surgeon who is doing the breast. Then you can have the pathologist, the oncologist, the important thing, the radiologist for the initial workup, and the breast care nurse. So in our setup, we have breast scanners, but she cannot attend all the meetings that we have. But these are the basic people that you should have.
What's the role of breast scanners here?
Yeah, so role of breast scanners is it's a vast area to discuss. So they how to break if you come across and you have diagnosed a patient with breast cancer, to tell the patient about this, and sometimes he will plan different things. Okay, I want to do breast conservative surgery to this. Then the breast scanners will raise their hand and say, no, she has sort of family issues like this. So we can't allow, she cannot go to Mammogram to have radiotherapy for 15 days. Nobody to take her. She can't travel. She can't drive. So then those instances, we have to respect those views, and we have to rethink and change our management plan. So there's a big place for the breast scanners.
So if we summarize what we have discussed so far, so there are certain things in the history and examination which may raise high degree of suspicion favor of a breast malignancy. And there are risk factors, and there are high risk factors, and there are low risk factors in the history of breast cancers as well. We discussed most of them. Then once you clinically suspect of a breast cancer, you have to do radiological and histological assessment of breast cancer or this breast lesion before formulating a definitive management. And this is in the form of if the patient is above 40, bilateral mammography. It's important to have bilateral mammography and a focused ultrasound and image-guided true-cut biopsy, and not FNAC. And then we said, now these are, from here onwards, is a little different to the esophageal cancer, gastric cancer, and colon or GI gastrointestinal cancer. We don't do staging investigation in all patients unless they have specific symptoms suggestive of a metastatic disease in breast cancer. And we do these receptor status in breast cancer on biopsy specimens, which we don't do in GI cancers. And then with all these information, we have MDT meeting. So the people who participate in the MDT meeting were discussed, and now at the MDT meeting, we may have to make few decisions. Suppose this patient has lymph node positive T2 lesion and the receptor status are positive, ER/PR positive lesion. How do we proceed, Nalinder?
So ER/PR, and if HER2 is also positive, all three are positive.
No, HER2 negative, ER/PR positive.
So ER/PR positive and is T2 cancer, and lymph nodes are in nodes. That's the patient that we presented today. So then we can offer upfront surgery. So we can do wide local excision and axillary clearance. We can tell the patient we can offer this, not necessary to take the entire breast out or a mastectomy. Mastectomy is also an option, still an option, but you can say there are other procedures as well. And for the no need to give neoadjuvant chemotherapy in this instance.
Okay, so there is a category of patients whom we can, or subgroup of patients whom we can offer a curative treatment where the primary modality or the first modality is surgery. It may be mastectomy, total mastectomy, or
breast conservative surgery.
Breast conservative surgery. So who are the patients may need neoadjuvant modality of treatment, and what is the neoadjuvant modality if you are going to offer?
Yeah, so patients who are having T3 or T4 cancers, there's a place for neoadjuvant chemotherapy and neoadjuvant therapy. But if it is hormone receptor positive, HER2 negative, even if you give chemotherapy, they are not very responding to chemotherapy. So then in this instance, you can give, there's a place for, especially in T3 cancers, you can give neoadjuvant endocrine therapy. And but the only problem in neoadjuvant endocrine therapy, it's safe and it works, but it takes time to work. It takes at least the maximum, the effect of the neoadjuvant endocrine therapy, you can see in about 3 to 6 months time after starting. But for the patients who are HER2 positive or triple negative, then there's a definite place for neoadjuvant endocrine therapy. But the tumor has to be T3 or T4.
Okay, so T2 below tumors or T2 tumors, we go ahead with surgery, and if it is above that, we consider neoadjuvant treatment, and the type of neoadjuvant treatment depend on the hormonal receptor status of the tumor, and this is a big difference between GI malignancies and breast malignancy. Now, GI malignancy, it is only the radiology will decide a place for the neoadjuvant treatment. Here, the receptor status also play a big role in deciding the type of neoadjuvant treatment. Right. So you were mentioning about breast conservation and total mastectomy.
Yes.
Both. Is the outcome similar? in terms of disease cure or the overall survival and local recurrence, or is there any difference?
So the disease-free survival and the overall survival is almost comparable in these two modalities.
But before that, sort of in cancer surgery students, the main final long-term targets are the disease-free survival and the overall survival. These are the main two targets. Yes, Nalinda, go ahead.
So breast conservative surgery, when you do, it has to be invariably and mandatorily followed up by radiotherapy. So the trials done has shown if you don't do breast conservative surgery and if it is not followed up by radiotherapy, then the results are poor. But if you do breast conservative surgery plus radiotherapy, the results are equivalent to mastectomy. So there's no need to worry. The results are comparable. So you don't get the wrong idea, students, that if you do a wide local excision, there will be a risk of having a cancer recurrence rather than doing a mastectomy. It is not so.
Provided it is covered with radiotherapy.
So we treat the rest
radiotherapy is given only to the diseased breast and not to the opposite breast.
Yes, that's right. That's right. Okay.
So because there is a high risk of developing metachronous malignancy, which can be reduced by giving radiotherapy, you have to give radiotherapy to the patients who are undergoing breast conservation therapy.
Yes.
Right. So suppose this patient is undergoing a mastectomy.
Yes.
Are we, if he didn't have clinically palpable or radiologically detected lymph nodes,
yes,
do we always have to deal with the axilla as well?
Yes. So breast cancer surgery, there are two types. I mean, you have to address the breast and you have to address the axilla. So axillary assessment is separate. So if you don't have radiologically or clinically positive nodes, then all those patients need to be subjected to what is called the sentinel node biopsy. That is to assess and to stage the axillary status. So sentinel node biopsy.
Can you say what do you mean by sentinel node biopsy?
Yeah. So sentinel node biopsy theoretically what means is the first node that drains the breast. So how to find the nodes? So there are about 20 to 30 nodes, axillary nodes in the axilla in different groups. So altogether. So what we do is there are two methods. What we do in Sri Lanka is the dye method, the blue dye. So the blue dye that we use is the 1% methylene blue. But you can use patent 5 also, which is not available freely. And the other modality is the radioisotope, the technetium-99 label radioisotope. You can give. So when you give a blue dye or the technetium-99, the radioisotope, you give it to the subareolar region, because the subareolar plexus, you have the lymphatic plexus of Palpate. So from there, it will go into the lymphatic system and go to the axilla. So the first node that encounters this blue dye or the isotope will harbor that, and also the first few other nodes. So theoretically, you have to remove the first node and see whether that is the sentinel node theoretically, but by definition, there are other nodes as well. A lymphatic that is leading to a node, although the node is still not turned into blue, or is not still hot with the gamma probe when you assess the radioactivity, it is also taken as a sentinel node theoretically by definition, because the lymphatic was draining to that node, although the node is not turned into blue.
How do we assess this lymph node during surgery, Nalinda? Now, do we have to send it to the pathologist to do a formal histological assessment and wait for another week to do it, or do we assess then and there?
Yeah, several years back, when we were also doing this here at Ragama, we had some person inside the theater. When I harvest the node, he will carry the node and run to the pathology department and do an imprint cytology or a frozen section, and we will wait in the theater at the hospital until they give us a ring and tell whether the nodes are positive or not on the imprint cytology, the frozen section. Because
So
if
that
it
may
is
take about 20
it,
to 1 hour, 20 minutes to 1 hour.
Yeah, at least 45 minutes. So that's right, about 1 hour. So then if it is positive, we have to then and there do axillary clearance. But now things has changed. But because if you see in the West, they don't do like that, because people found out that even if it is positive, still you can treat the axilla with radiotherapy. So if you you harvest the sentinel nodes and you send it to assess with formal histological assessment with the other breast, the malignancy, the specimen. And when the report comes, if the nodes are positive, you can have a dialogue with the patient and say, so there are two modalities that you can either give radiotherapy or you can do axillary clearance. So both are benefit and both are very effective. But if you give radiotherapy instead of axillary clearance, the side effects of axillary clearance are 50% less in axillary radiotherapy. For example, lymphedema or shoulder stiffness, or the range of motion that is going to be reduced with axillary clearance. All the complications are at least exactly 50% less in axillary radiotherapy.
And
But
yes.
So if the patient, it's a patient choice actually. So even if it is triple negative, or we think you can, I mean, think that this is a triple negative cancer, it's a young patient. So if the node, now we did a sentinel node biopsy that is positive, shouldn't we do axillary clearance instead of axillary radiotherapy? No, the answer is no. We have to go by the evidence. Evidence suggests there's no need to do that. And other thing is the number of nodes that you harvest is the most important thing. So some time back, we were taught as sentinel node biopsy, you harvest the first node and take it out and examine that. That is wrong. If you do that, if you harvest only one node, the false negative rate goes up. So what the data suggests is, if you take only one node, the false negative rate is around 18 to 20%. So it's pretty high, isn't it? So what you need to do is to harvest at least 3 or more nodes. So with the blue dye, if you really see now, when we are doing a surgery, we find we harvest sometimes even 6 nodes with the blue dye. So it stains that much. Only thing is you need to know where to look for the nodes. If you look properly, there will be nodes. And if you have the radioisotope, it's pretty easy, because it will definitely give you the heat signal with the gamma probe. But even without that, even with the blue dye, you can still harvest 3 or more nodes most of the time. If you harvest 3 or more nodes, your false negative rate drops down to less than 9%, which is acceptable internationally.
Right. So the most of the complications, or most of the post-operative complications of breast surgery for malignancy is due to the axillary surgery. Removal of the breast may lead to sort of only few complications, and they are not huge as well. So nowadays we are trying our level best, our best of our ability to reduce harming the axilla. So one modality is doing the sentinel node biopsy and treating the axilla with radiotherapy. Okay. What is the real importance of knowing the status of the axilla, Nalinda?
So that is sir, that is for the staging of the patient with regard to the breast cancer, and to decide on the systemic therapy. So
Right.
if the nodes are involved, so now even they look what is called the micrometastasis. What we report as involved node is what is macrometastasis, and micrometastasis is you have tumor less than 2 millimeters in size. So that is micrometastasis. And if you have isolated tumor cells, that is at least 200 cells, that is called isolated tumor cells. If you have micrometastasis even, that is good enough to decide on systemic therapy. The systemic therapy can be chemotherapy and neoadjuvant, chemotherapy and endocrine therapy. That is adjuvant. Yeah.
So it is also similar to GI malignancies, colon cancer, esophageal cancer. So we remove lymph nodes not to cure the disease.
Yeah.
It has a more prognostic implication. If the lymph nodes are positive, these patients have a poorer prognosis and they have a higher chance of developing metastatic disease. So that has to be covered with adjuvant modality of treatment. In breast cancer, it is chemotherapy as well as hormonal manipulation, hormonal therapy.
Yes.
So it is important to understand that concept. We treat axilla just mainly to gain some information to see whether he is benefited with adjuvant therapy. Right. Okay. So now this patient undergo mastectomy, probably axillary. He had sort of axillary nodes as well. So he undergo axillary level 2 axillary clearance as well. Why do we do only level 2? Why can't we go up, right up to the total axillary clearance?
So the evidence says even if you, this is for prognostication and to decide on the systemic therapy. So
Yes.
you can address the level 3 with systemic therapy. But if there's gross disease in the level 3 as well, if there is, then you can, there's no ruling to say you don't have to remove even then. So if you come across level 3 grossly involved nodes, if you can take them safely without disturbing the or damaging the axillary vessels, you can take it out. But you can treat them with systemic therapy, with the chemotherapy and the hormonal therapy.
Right. So what are the common early post-operative complications, or what are the complications you should anticipate following mastectomy and axillary clearance?
So early complications are the in breast surgeries, hematoma, and in a couple of days' time you will have seroma formations. So these are the commonest things. So the pain is students come and mention pain as a complication, but it should not be. These are the commonest things that we encounter in breast surgery: hematoma and seroma formation. And sometimes later you will see sometimes wound adhesions in the mastectomy specimens and the bone edge necrosis if you have sutured under a lot of tension.
Okay. What are the nerves at risk during this procedure?
So in the axillary clearance, you will come across mainly the three nerves. You will come across the thoracodorsal nerve, that is the nerve supply to the latissimus dorsi. It is deep down in the posterior wall on the latissimus dorsi muscle, and it comes medially and joins the thoracodorsal pedicle. The thoracodorsal vascular pedicle comes directly downwards from the axillary artery and the vein. Then you come across the long thoracic nerve, which is the nerve of Bell. The long thoracic nerve comes and it's passed to the lateral chest wall, supplying the serratus anterior, and it is covered by the fascia. But sometimes you will find and preserve this long thoracic nerve below. But if you follow it upwards into the axilla, you can easily damage it when you are doing a level 2 clearance. So you need to, once you find the long thoracic nerve down below, where it's very easy to identify it because the serratus branch from the thoracodorsal vascular pedicle goes and meet the serratus muscle. The serratus nerve the long thoracic nerve will cross there. So it's easy to find it. And if you trace it upwards, you will see that it is going up into the axilla, and it is easy to get it damaged when you're doing a level 2 clearance. So we have to be mindful and very conscious about it when you're doing a level 2 clearance. Then the other thing is you can have this
Intercostobrachial
nerve which can be, if you can safeguard it and do the resection, that's fine. But if you have to sacrifice it, there's no problem. You can sacrifice it. In the West, they don't try to even preserve it. They always cut it out. But here we try to preserve everything. But the patients, not surprising, they will come and tell that there's a bit of numb patch in their upper inner arm.
Right. So there are 3 nerves at risk. One nerve is usually, in my hands, invariably damaged, that is intercostal brachial. And other 2 has to be preserved, and those 2 are at risk in the axillary surgery. So again, I'm stressing the axillary surgery carries main post-operative complications of this surgery. Okay. So what are the late complications you may develop after mastectomy and axillary clearance?
So late complications are most
or we'll ask like this, sort of what advice you give nursing staff and the patient after now right side mastectomy and axillary clearance to avoid long-term complications?
Yeah. So you have to tell them to, to encourage to do physiotherapy, but not aggressively. So it has to be a limited physiotherapy that you start for that, say, ipsilateral upper limb, that is to prevent the shoulder stiffness, especially after axillary clearance, not after sentinel node biopsy, after axillary clearance. So otherwise they will have a lot of shoulder stiffness and the range of movement will be becoming less and less. And they need to protect their arm. So because we have done axillary clearance, they are prone to develop lymphedema and they are prone for infection. So we have to tell the patient and the nursing staff not to put any cannulas or not to draw blood from that ipsilateral upper limb, or even for instance, we tell not to even put the blood pressure monitoring cuff to that side as well. So not to, that is to say, there's no any form of trauma should not be done to that upper limb. Then they should not carry heavy weights. If they are doing household work, they should not be, you have to advise them not to lift heavy flower pots or something like that. Even when they do margarine, not to carry heavy bags. So internationally, what they say, not to carry stuff more than 4 to 5 kilos from that side. And encourage the range of movements and the physiotherapy. And also if they notice any swelling in the arm, they have to come and meet us, because there are special exercises and physiotherapies to and stockings to give to prevent the formation of lymphedema.
Right. So to avoid lymphedema and sort of we should avoid any form of injury to that upper limb. Okay. Again, now when we are planning post-operative chemotherapy, suppose this patient is positive, is having positive lymph nodes.
Yes.
So you said sort of these patients are going to get adjuvant chemotherapy or hormonal therapy.
Yes.
So what are the different types of hormonal therapy, and how do they, who are the patients going to be benefited with hormonal therapy in breast cancer?
If your patient needs chemotherapy, so first you will give adjuvant chemotherapy. So most of the time we give FECT, that is 5-fluorouracil cyclophosphamide 4 cycles, followed by 4 cycles of docetaxel. So for the students, it may not be that important. So whatever you give, 8 cycles of adjuvant chemotherapy, because you can't give chemotherapy and hormonal therapy at the same time, because the mechanism actions are different. If you give endocrine therapy, hormonal therapy first, then you can't, that patient's cancer cells become non-responsive to chemotherapy, because hormonal therapy act by cytostatic mechanism, and make them, the cells will die by apoptosis. So the mechanism of action is different. So if they are become cytostatic, the cytotoxic chemotherapy won't affect. So the chemotherapy will act on rapidly dividing cells. So if the cells become static, they won't act on this. So you have to always give chemotherapy. If your patient needs chemotherapy, first you give chemotherapy, and later on you can start them on hormonal therapy. So hormonal therapy, there are mainly two broad arms. That is the what you treat for premenopausal ladies and for the postmenopausal ladies. Premenopausal women, you treat with tamoxifen 20 milligrams daily, and postmenopausal women, you treat with aromatase inhibitors. So the examples are letrozole, anastrozole, and exemestane. So anastrozole and letrozole are non-steroidal aromatase inhibitors. Exemestane is a steroidal aromatase inhibitor. So usually you treat 5 years of endocrine therapy, but now there's recommendations saying extended endocrine therapy for patients with higher NPI. If the prognostication is very poor, so you treat with 8 to 10 years, and then the results have shown that there's a benefit.
So broadly, what are the benefits of endocrine therapy? Is it the local recurrence, metastatic disease, or disease in the contralateral breast?
So all three that you mentioned, sir, so those are the benefits. So you reduce the recurrence of the ipsilateral breast, you reduce the recurrence of a cancer in the contralateral breast, and you, if there is any cell that is harboring or dormant in other areas of the body, the metastatic sites, those will also die. That is the idea of treating them with endocrine therapy for a longer duration.
So we treat it for 5 years.
Yes, yes.
We don't sort of, I thought we don't go deep into the breast conservative arm, but sort of knowing that it is a modality of treatment, but always it should be supplemented with radiotherapy. And the major outcome in terms of long disease-free survival and the overall survival is equal to mastectomy. If you know that, that is more than enough. Yeah. And that preserves your body image as well. That is the main advantage of breast conservation. Right. Then we talked about the problems of axillary surgery and what information we can get following axillary surgery, and major complications as well, and how are we going to avoid them. And then we talked about the place of adjuvant treatment, chemotherapy, as well as hormonal therapy, and the main benefits of those things in terms of metastatic disease, local recurrence in the ipsilateral breast, and disease and the contralateral breast as well. Nalinda, anything else we should discuss today?
I think we have covered a broad aspect. So I think for today, I think that should be enough. We did start from the triple assessment. So and touched on some surgical management and the adjuvant therapy as well. So I think that should be okay for today.
And triple assessment and triple negative breast cancer are two different concepts. And
two different concepts, and students tend to mix them up, especially in the exam setup. So for example, so the last your immediate last batch. So I gave the scenario of a 30, I can't remember the age, 29-year-old lady with diagnosed as triple negative breast cancer, and I asked, what do you understand by triple negative? So one candidate has written, if it is triple negative, that means by all aspects it is negative for cancer. So then there's no cancer in this patient, and hasn't even wrote a single answer for the rest of the questions as well. So don't get mixed up. So triple negative is the receptor status is negative. So that is ER receptors, PR, and the HER2. Triple assessment is what to assess clinically, radiologically, and histologically.
Right. Any questions from students?
One student has asked, what's the place for tamoxifen?
So I think we mentioned.
Yes.
Yeah. Anything else? Any questions?
Okay, in the absence of any more questions, we'll wind up. Thank you very much, Nalinda, and thank you, Pinto, as well. And probably we may meet again during the course of this week because we have more holidays.
Okay.
Okay, sir. Okay.
Okay. Good night.